All right, I am so excited to be here today, and thank you so much to Eyes on Eye Care and Zeiss for putting on this event. Really exciting discussion in regards to not only glaucoma, but our number one concern, progression, when we're treating these patients. So in lieu of time, I'm going to get straight to my case. I have an 83-year-old African-American female with primary open-angle glaucoma who's been medically managed in the clinic for 11 years. This patient has a Tmax of 28, and she is, fundus photos are displayed here, and you'll notice that there's a marked asymmetry between the left and right eye, and almost a complete obliteration of the rim between 3 and 6 o'clock on the left eye with a corresponding RNFL wedge defect. This patient, like I said, has been on medication treatment only. She's on 3 different drops, in addition to 7 systemic medications. This is an 83-year-old patient. I'm about half her age, and I have about a 70% compliance with my 1 multivitamin that I take at night. So you'll be sure that we're concerned about compliance when it comes to this patient. We're asking a lot. Her OCT results from her latest visit are here. And as you can see, they very nicely correspond to the clinical picture. So in the left eye, we notice thinning of the RNFL and the neural retinal rim when you compare the right and the left eye. We don't have normative data on the neural retinal rim thickness because she has a large flail opening, but we can certainly see the discrepancy between the two. And like I said, it matches the clinical picture, which always makes me happy. So because of the max medication, we've had multiple conversations regarding other interventions, including laser and surgery, but this patient is very resistant and very hesitant. Her visual field test latest is shown below. It's pretty marked change in the right eye. And in the left eye, we have some central defects, which are concerning, of course. And I like to utilize these fields, especially in my patients who are resistant to additional treatment, to try and hone in on maybe understanding what we're looking at here as far as our goal of preservation of vision. Unfortunately, or fortunately, this patient, despite these central defects in her left eye, has no impact of her activities of daily living due to her vision. So in her mind, she sees fine. She's doing everything that she wants to do in her day. So why should she have to put herself through surgery? And she has a lot of anxiety with that. If we look at her progression, again, it matches the picture. So we have progression on our OCT, and especially in the inferior area, we notice a rate of change of minus 2.71 microns. As Dr. Epshtein pointed out, this is a significant amount of change, well above the age-related change. And in our mean deviation, our visual field, we have a significant level of change as well. So the case is pretty clear cut, and I hope you agree with me. It looks like this patient has glaucoma with progression. So I guess the real question is why are we even discussing it? Well, let's think about how we're utilizing progression analysis and maybe how we can utilize the tools with our system in order to really look at the complete picture. So these baselines were taken in 2012 when the patient first presented to clinic. However, there's been a lot that's changed in the past 10 years. First of all, the fields were done before we even initiated treatment. We initially initiated treatment in 2013. After that, she had 2 changes in medication, 2 new additions due to insufficient IOP levels. And shortly after, in the COVID era, she was lost to follow-up, as most of our patients were, only to present back to clinic with a new APD in the left eye that we would assume to be from this progression. So as we're treating these patients and intervening in the disease, doesn't it make sense to kind of reset our baseline after we initiate some treatment to really decipher if we're having change after our last intervention and really how our interventions might be impacting this level of change for the patient? So when was the last Changeup? And let's move the baseline. One of the things I love about the software and the tools that we have available is just the imagery. I'm a photographer by initial trade. So in this image here, where we have a progression indicator line, we have 2 drop icons. These represent the most latest changes in her medication, which were changes in drops. And looking on the left here, this is our moved baseline. And I chose this baseline to when she returned to our clinic after she was lost to follow-up. She did have an alteration to her prostaglandin more recently, but GPA needs at least 5 fields in order to run progression. And unfortunately, I just don't have enough data to show you that yet. So let's even just change from back when she represented to the clinic and just see if that makes a difference in our calculation. So when we calculate GPA based on her initial visit back in 2012, and some of the OCT images were a little bit further after that, we do see a big change in the inferior temporal RNFL as expected. And then down, we're seeing likely progression as far as the indicator for progression as GPA is concerned. If we look at the adjusted baseline to when she represented back to clinic after being lost to follow-up, we still see the RNFL loss in the inferior area. However, what we're noticing is that our progression indices and our slopes are more flatlined. We're not seeing quite as a significant rate of change as when we compare to her first field, which you remember is prior to starting treatment. So that's fine, but isn't progression progression? Well, it really depends on what we're thinking about. If we look at the complete picture, we look at our 2012 baseline prior to treatment, we have a rate of change of 0.8% in a year, which again is significant, is a severe rate of progression. But if we adjust the baseline, we cut that in half to 0.4, and we're looking at a much slower progression now that this patient's back on track, taking medications and with compliance. So when we revisit our goals, our real goal is to determine the rate of progression, and really that's so that we can hopefully accurately predict the risk of visual acuity loss. One of the things that we do in order to analyze this is some of the techniques that we've talked about today with field testing, GPA analysis, and OCT. But the other thing that I think is of major importance is us as providers initiating more treatment early and at any point where there may be an intervention. So there was a study that was done that displayed the rate of progression and how it could be detected by doing fields once a year, twice a year, or 3 times a year. And that's displayed in this chart on the right. So let's take the -1%, which is the mean deviation that we labeled as severe progression, okay? If we just do 1 field a year, we're looking at a 6-year increment with a low variability field, which we all know is hard to obtain. If we do 2 examinations a year, we cut that in half, so we can actually determine the rate of progression in 3 years rather than 6. And if we do a triannual visual field, then we go down to 2 years before confidently detecting rates of change. So I think this speaks a lot to us, but in our busy clinics, it's hard to get patients in for fields. But it's certainly something to consider if we're really focusing on this rate and how it impacts our patients. So let's go back to our case. Our patient's 83 years old. She has a central defect in her left eye, which we're concerned about, but it's been there for quite some time. She's asymptomatic, so she's very resistant to surgical intervention. She was lost to follow-up and was non-compliant with medications in the past, but now that she's returned to clinic, we've kind of reiterated the importance, and she seems to be on track with excellent eye pressure and a lower likelihood of progression as GPA is recalculated. So my take-home points for today, our rate of progression is guiding our treatment. So the best thing we can do for our patients is to test early and to test often. And don't forget to change the baseline. There's value in adjusting the baseline for the most recent intervention in order to see your level of progression and hopefully how it changes as we dictate the course of disease by intervening. Thank you so much.
All right. Another great case illustrating so many awesome points. Again, I think, one of the questions that we always are asked is, how much testing should I be getting? And we talked about that sort of with the last case. And I think it is important with visual fields. My question for you, Jen, with this is, I have a lot of people, that are working with me, and they're always they're always asking, hey, when should I get a 10-2? Should we be getting a 10-2 here? Does that eat into sort of the number of fields that we get per year, since we can't really track progression with a 10-2? Should we just get the 24s? I'm just curious your thought on that.
Yeah, so we will often get a 10-2. I typically will get 2 to 3 fields a year, and often will interject with a 10-2 when there is some central defects that are noted. It is just so much nicer to kind of zone in on that central area to see small areas of change, especially in this case here. Some of these central areas, it's a point here, it's a point there, there's some spreading in between. But once you get a dense cluster of a few areas, that are kind of stable, I think that's when it's especially important to kind of zoom in on that area to better detect those changes.
Dan, are you comfortable doing a 24-2C only on this patient to track that left eye?
I think for this patient, maybe initially I would start with 24-2C, but once I see these defects, I would also get a 10-2, probably at least once a year for this patient, just because the defects are predominantly in that central area.
Okay, now I think those are great points. I think this is one of those tough cases where sometimes you'll see this patient, despite good treatment, sometimes that defect does just get denser, and you have to remember that there are pressure independent risk factors that sometimes affect the rate of change. The big thing for me, I think, here is number one, asking the patient about what they notice, because though we may try to track the visual fields, just listening to the patient is so important. They will often know if that vision is getting worse. And then number two, look at the patient's, age and sort of the period of time that they've had this disease. At 83, the big question is this patient going to lose functional vision in their lifetime? I think the answer is probably no. Now let's flip it a little bit. Let's make this patient 20 years younger. And I'm curious, what would your target be, Jen, for this patient's left eye? Your target pressure.
Yeah, so
what would you do? How aggressive would you be?
Yeah, so if a patient, were younger, I think I would be much more stringent in my discussion as far as intervention besides medication. And unfortunately or fortunately for this case, she's so comfortable with her vision as it is. But in a younger patient, just describing the years left in their life and how this has progressed so far, I think it's really important. And often I will pull up the visual field, specifically the gray tone. I just think it's the most comprehensive for patients to understand and show them change over time. And sometimes that does the trick. There's going to be some patients who just flat out refuse. But more often than not, I feel like actually going through and taking the time to run through some of the images with them does help.
I would 100% agree. Dan, quick question for you. Again, I like to mix up the case. I like to take this as a starting off point and then modify it a little bit. This patient, say they are a little younger and they have some cataracts, and they're asking me about, what your thought is. How do you sort of counsel patients in terms of, when you're maybe sending them off to have cataract surgery when they have a central defect like this? Do you tell them anything different from some of your other patients?
So if they have a central defect, I think I'd kind of push them more, maybe get cataract surgery a little bit earlier, actually, so they could get a mixed procedure. Because as you mentioned, we might be able to be a little more aggressive, especially if they're a little bit on the younger side, because we don't want their vision to be affected as they get older and kind of really affect their functional capacity.
Yeah, I think it's an interesting question. We look at sort of the way we grade glaucoma: mild, moderate, severe. So we have our pre-parametric disease, really mild, our moderates, visual field loss in one hemifield, and then our severe can really be all over the map. We got these patients with very central loss, and then we have others who have these dense superior and inferior arcuate scotomas. And so I don't think it's the best grading system, but it's what we have. But I'll tell you, a patient like this, it's tricky because I think you see that location. It is central. Sometimes, actually, I find that patients who have a decent amount of cataract actually don't notice a defect quite as much, and then you take the cataract out, and they're like, "When did you put that there?" And it's like, no, that's been there the whole time. So I agree with Jen. I think it's really important to show them what's going on, to illustrate to them. And that's why I think having all the testing is helpful, because for a lot of our patients, when we need to counsel them for something like cataract surgery, it's nice to show them, what they might actually see moving forward. And so I think that's a big point from this case is, educating the patients. They want to be involved, I think, in understanding what's going on. It's not just us sitting there behind the screen, looking at all of the images. And so just lastly, each of you, just quickly, how often do you get no CTs in this patient?
So anytime I have a change in intervention, I try and get an OCT about 3 months afterwards. And then typically, if there is any sign of progression, I might be doing it on a 6-month basis rather than on the typical annual basis.
Yeah, I agree. I'd probably get an OCT every 6 months on this patient.
I'd say that's the biggest change in my practice over the last few years. I used to do OCTs really just once a year. Now I'm getting them at least twice a year, sometimes even 3 times a year, but I do think twice a year. I am starting to see more change. I think we're able to better understand, if a defect is getting deeper or denser, and the whole structure function, issue is just so important. So again, awesome cases. Thank you guys so much.